Good evening, everybody. Welcome to the next in the series of webinars in relationship to COVID-19. Tonight we've got Ruth Waitzberg, who is talking to us from Berlin. And she's going to tell you a little bit about how she came to be there and what she's doing there. And then she's going to tell us about the work that she's been doing on the subject in relationship to Europe and Israel. So, Ruth.
Thank you, Professor Katz, and it's a pleasure and an honor to be here this evening, and thank you for everybody that decided to come and hear me. So I am a researcher at the Brookdale Institute that is based in Israel, in Jerusalem. And actually I am Ola Hadasha, not so Hadasha anymore. I am originally from Brazil. I was born in Brazil. I moved to Israel for my studies. And I started working at the Brookdale Institute about 10 years ago at the health policy team. And I came to Berlin to finish my PhD, which is a joint PhD between Ben Gurion University of the Negev in Beersheba and the Technological University of Berlin. And so we have been living here in Berlin since summer 2019, and it's been very nice, a good experience despite COVID and everything. And here in Berlin, I also work as the Israel representative of, Brookdale Institute is the Israeli representative of at the HSPM. HSPM is the Health Systems and Policy Monitor branch of the European Observatory of Healthcare and Systems. And what we do is that we report about interesting and important policy reforms and changes that occur in Israel to the world, and we learn from other countries. We are a network of researchers, and we meet once a year, and we learn about what has been done in other countries. And now that COVID is in our lives, we report how each of our countries has responded to the pandemic. And I have been reporting about the Israeli case, but part of our work is also to learn from other countries and recommend policy measures and responses to the Israeli government. And what I'm going to talk about today, and maybe I should share my screen already, is about some selected health systems and policy responses to COVID in Europe and in Israel in the first half of 2020. And we will try to learn how we can improve policy responses for future waves. We hope there won't be so many, but probably there will be some, and we want to be better prepared. And this talk is, I based my work on the work I have been doing at the European Observatory and also at Brookdale Institute. So in March, when COVID just started in Europe, the European Observatory of Health Policy and Systems started to build a platform so countries could report what was occurring and how governments were responding to the pandemic. And at that time was very little evidence, and governments and ministries of health were really seeking for any kind of evidence, any kind of best practices, any kind of lessons from other countries of how to better respond to their own pandemic. And I remember that the government, the Israeli Ministry of Health approached me and asked me, you are in Germany, tell us what Germany is doing. And I remember that representatives from other countries, from Belgium, from Malta, were calling me and asking me about what was being doing in Israel, for example. So this platform made a kind of a database of how countries were responding, and we constantly update this platform, and it's very useful because now we have also cross-country comparisons on specific topics that are very interesting, and a lot of analysis of key themes across countries. So if you are interested, you can go and have a look. The presentation I'm going to present today is based on one of the main outcomes of this project, that is the publication of EUROHEALTH that was published 2 weeks ago. And there are a lot of articles with a lot of cross-country comparisons on policy responses to COVID, and this is interesting. So if you are interested in the sources that I am citing, they are all here. So if you get the presentation, you can easily reach it. So the presentation outline is the following. I chose 3 main topics to talk about. The first one is public health, because this is the main tool to curb the transmission of the virus. And I will talk about some challenges and responses or strategies to overcome these challenges in a lot of countries. And then I will talk about acute care, but I will focus on strategies to expand workforce capacity, and I will explain you why I chose to focus on workforce capacity. And then I will talk briefly about financing of healthcare and COVID. So in financing, we have 2 topics. One is compensation for providers that lost income during the first lockdown because all elective care was put on hold and a lot of patients forgone care, and many health providers actually lost money. And this is counterintuitive, right? Because COVID was overwhelming the health system, but there were a lot of providers that actually were losing income because of the lockdown. And the second topic within health financing is how to properly pay for providers, because they have increased expenditures, all the personal protective equipment, hygiene regulations, physical distancing requirements. COVID patients are complex and they have to be properly reimbursed. And finally, we will try to learn lessons for future waves. We hope there won't be too many, but if there are, we have learned already some things about how countries have responded. So let's start by public health. There is any country that wants to ease lockdowns and wants to enter into some kind of routine with COVID has to have a good system of, they call it FTTIS, find cases, test cases, trace them, isolate them, and then support so they comply with quarantine. And there are a lot of challenges and responses in this whole chain. So let's see what are the challenges and how countries have overcome it. So the first one is that in order to find the infected people, you need to test them. And testing is very important, but it needs countries need to produce and procure testing material. And at the beginning of the pandemic, testing material was scarce, and the antigens and all the products were not available in the countries. So the testing requires reliable supplies of a lot of materials. So swabs, transport media, reagents, primers, PCR machines. And the first countries that started to produce this equipment and this material in-house were Germany, Norway, and the UK. And other countries, they had to buy it from overseas, and mainly from China. And this was a big challenge because the market was desperate for this kind of materials, and there was a lot of competition, and the countries invested a lot of money to buy this testing material. And I remember at that time that Israel, for example, bought a lot of testing equipment and material, and it turned out to be not proper or not high quality or not secure enough. So it was a big challenge at the beginning. Now all the countries, or almost all countries, produce in-house their own testing material and equipment. And this is something that was done throughout and while time passed. The second challenge is ensuring access to testing, right? Because you have to get more people, or the most people tested as possible, because then you can figure out who is infected and isolate them. So what happened in the first half of 2020 was a movement from centralization to decentralization of testing. So at the beginning, most of the countries were conducting tested in very few settings, for example, in only certain hospitals. And there were long queues for testing. There were not a lot of tests, materials and equipment anyway. So the capacity was somewhat limited. But now, while countries started buying and producing their own testing materials, they started decentralizing the places where people can get tested. And this is very important because not everybody lives near a hospital or has an easy access to hospitals. So now a lot of countries are conducting tests in primary care clinics. A lot of countries built drive-through or mobile testing units. Some countries even test people at home, for example, Austria, UK, and Estonia. And I remember that in Israel, at the beginning of the pandemic, the Magen David would come to the houses of the people that had symptoms and would test people at home and take the swab to the laboratory in the hospital. So this was a way to improve the access to the test. And there are some countries that have outsourced the testing to private companies. So Finland, Estonia, and UK, where the public health system was not enough to provide testing for everybody. And even though there are a lot of countries that face challenges of access to testing. And for example, here in Germany, we are in the second wave, and there are long queues for testing, and people that are eligible for testing do not have access because they don't have enough equipment or enough places or enough workforce. So it's a challenge to curb the spread of the virus. The third challenge is the rapid transport of samples from the testing sites to laboratories, right? Because we have now that the testing sites were decentralized and they're spread all over in primary care clinics, you have to transfer them to the laboratories, and countries don't have as many laboratories as primary care clinics, for example. So what they did is that countries have improved the capacity of laboratories. They have not only increased the number of laboratories, but also the capacity of laboratories. And some countries were very creative and tried to deliver these samples with drones. For example, in Estonia, they found this creative solution. And there are still some countries that have some bottlenecks or problems in reaching the laboratories. For example, in the UK, most of the testing takes place in 7 mega laboratories, and this can be a challenge for people to reach these laboratories if they don't live very close to it. And if the tests are conducted in the primary care clinics, they all have to reach only 7 laboratories within the whole country, and the country is quite big, so sometimes it can be a challenge. The fourth challenge is increased laboratory capacity. As I said, it's not enough to have the testing, but we have to have the capacity to make the results and also notify the people about the results. So many countries expanded the existing medical laboratories and even repurposed other laboratories in order to make COVID testing. And in Israel, that happened also. So a lot of laboratories that belonged to the health plans, to the Kupot Cholim, were converted into COVID laboratories, and they gave preference to this kind of testing instead of other blood tests and things like that. All the personnel and all the capacity was focused in COVID testing. So as I said, UK preferred to have few centralized mega laboratories. Maybe it has changed since then, since we have made this study, but at least for some time ago, it was the case. There are countries that don't have enough laboratories and weren't able to increase the capacity. So they send samples abroad for testing. For example, Ireland and Finland. These countries, they send the samples to other countries and receive the responses back. So I told already about Israel, and in Denmark, they use robots to increase the capacity of the laboratories, which is also interesting. The fifth challenge is the rapid initiation of contact tracing to reduce the risk of further transmission. So here, this is very important because if you have the test and you don't report the result fast enough for people, they won't quarantine, they won't isolate themselves. We know that quarantine is mandatory in many countries, but not always people comply with quarantine. But the statistics show that the people that do not comply with quarantine are those that are not asymptomatic. But all symptomatic patients, they stay at home. So it is important to report fast also for the asymptomatic and mainly for the asymptomatic if they are positive, because those are the most dangerous cases that can spread the virus. So many countries started to recruit new personnel to be contact tracers and work in call centers. So that happened, for example, in France, UK, and Germany. The public health system was not big enough to cope with the contact tracing that COVID requires, and they hired more personnel. There were countries that didn't find contact tracers to hire because there were no enough qualified people. So they recruited from other alternative settings. For example, the military. So Germany and Israel recruited the army. They trained the soldiers, and these soldiers are now tracing the cases of COVID and notifying the people that were in contact with the cases, and this way send them to quarantine. Finland preferred to use medical students, for example. Medical students could be very easily and fastly trained to be contact tracers, and Cyprus used volunteers, lay people that didn't have any training but were trained on the spot and then could do the contact tracing more easily. Many countries recruited primary care providers like nurses and GPs to help with the contact tracing because they were conducting the tests. They knew the results from their patients and they could call the patients and then trace back who were in touch with them and where were they, and they were this way the contact tracing was more effective in these countries. We know that many countries use the digital technology to trace possible contacts with a positive case, and we can see that this is very common now. At the beginning of the pandemic, Israel was one of the pioneers that started tracing people with digital technology. Israel has two main systems. One is involuntary and is done by the Secret Service. The other system is voluntary. It's an app that people can download and they are not obliged to download. And these systems warn you if you were in touch with someone with COVID, and they also report to the ministry of Health, and the ministry can also report through these apps to people that they were in touch with the COVID cases and they should isolate themselves. But while these apps deliver speed and can provide this tracing very easily and in a cheap manner, there is little evidence that they are effective because they depend on the coverage and the compliance of people. So the coverage varies a lot among the countries. So we can see that only 3% of the population in France download this app. And when you have so few people using the app, this is not very effective. In Finland, about 30% of the population downloaded it, which is quite impressive. But still, if you get a message from your mobile phone that you should quarantine, it's not guaranteed that you will do that. And this is a problem because we know that people sometimes refrain from downloading the app and using it because they don't want to receive this message that they have to quarantine. And if someone calls them from the Ministry of Health or from the Public Health Services, they would do that. So there is a good question. It's still a question of how effective these apps are in contact tracing. The sixth challenge is supporting people in isolation, because we know that if people will be isolated but won't have any assistance in buying supplies and buying medicines, then they will have to leave their homes and go and buy the supplies. So it's very important to support people in isolation. We know that there are people that cannot isolate because they live in crowded areas or because they have very big families and they cannot isolate in one room, or they cannot use a toilet for themselves. So countries have created accommodations for these people that have to self-isolate. And in the first outbreak, the first wave of the pandemic, that was very common in many countries, they have transformed hotels that were not being used anyway into quarantine hotels. So in Israel, it was interesting because there were hotels that were designated for the ultra-Orthodox Jews because these populations have more difficulties in isolating themselves because they live in crowded areas and because they have large families and they don't have every time one single room for a person to self-isolate. So moving the person that had to self-isolate to this hotel was a good option or a good solution. But what happened was that people didn't go get tested because they didn't want to be removed from their houses to these hotels. You can imagine that be by yourself in a hotel feeling very sick is not very nice. And the first wave was around Pesach, was around the holidays, and many people just did not get tested because they didn't want to leave their families. And this way the virus spread a lot in Israel. Another population that needs a lot of support with self-isolation is the Arab population, because they also live in crowded areas. They also have large families, and for them, it's also not easy to self-isolate. And for them, also, there were a lot of hotels designated for them, but the same challenge. Not always they get tested because they don't want to be removed from their houses. So it's important for the isolated people to have a nice environment, because otherwise they won't comply, or they won't even go and get tested because they don't want to be punished or to be taken from their homes. So it's important to provide them supplies and medicines. And countries have used fines for violators of quarantine. But still, if you give a big fine for violator and this violator just cannot self-isolate because they don't have the right place, or they have to go out to buy medicines for themselves, you have the risk of penalizing marginalized population disproportionately. So that's why it's important to support people in isolation. Other countries chose to monitor movement of the positive cases with their geolocation data through the mobile phones. And this was the case for Hungary, Iceland, Israel, and other countries. But the population was smarter than authorities, and many times they leave home and leave the phone at home, so they cannot be traced and they don't get the fine that they are violating the quarantine. So just to summarize the public health part of the responses, countries had to increase the capacity of testing, contact tracing, laboratories, and support people in quarantine in order to curb the spread of the virus. And this was the first measures that countries did when COVID started spreading. And this was in parallel to the second part of the presentation, which is acute care, because acute care is actually treating COVID patients, but also treating non-COVID patients, right? Because people keep getting sick despite COVID. We have the same diseases and the same problems as before the pandemic, and now we have the pandemic on top of it. So the acute care system had to cope with the regular problems and also with COVID on top of it. So the main bottleneck or the main problem of acute care is workforce. And why do I say that? As the same way that countries could increase the production of testing materials and increase the capacity of laboratories, they also increase the capacity of ICU beds and the capacity of internal medicine wards. And countries bought ventilators from China, and they started producing their own ventilators. So these resources, they're not bottlenecks anymore. On the contrary, countries now are stuck with a lot of ventilators that were never used, a lot of ICU beds that were not filled. So equipment is not a problem anymore, but health workforce is still a big problem. And the challenge remains very problematic. And so I already said that COVID led to a fast rise in demand for health professionals because, as I said, they had to treat COVID patients in acute and emergency care settings. But they had also to ensure the essential services for all the patients, also non-COVID patients. And at the same time, the health workers were those that most got sick and infected and sent to quarantine by the virus, because they were the frontline people dealing with the virus. So not only there was an increase in demand for workforce, a big part of the workforce was sick or isolated and could not provide care. And we have here huge numbers. For example, 7% of total health workforce was in quarantine at some point in Germany, 14% in the UK, and it reached even 20% in Cyprus and Lithuania. So also countries had to recruit physicians, nurses, and other health professionals from all over. So let's see how they did it. So the first strategy to recruit health workforce was from alternative settings. So first of all, started landing health professionals from, for example, surgical wards or from other kind of hospitals to treat COVID patients. Everybody stopped what they were doing and they started treating only COVID patients. Countries started hiring medical and nursing students, and they started working as professionals, even though they were still students. They could be those that were already in their final stages of their education and training, started working and treating COVID patients. Countries hired retired health professionals because these were experienced people and could easily provide the required care. Many countries have inactive health professionals, and countries started recruiting them to fight the pandemic. Many countries also started recruiting professionals from abroad. Those countries that could import professionals did it during the pandemic. They also recruited volunteers for many tasks that are less professional or less medical tasks to support the hospitals and support the care. And a lot of countries also recruited from the military, from private sectors, and from overseas. So, for example, in many Mediterranean countries, the government obliged professionals that worked in private hospitals to give to start working in public hospitals. So there was a change in the interface and the mix of public-private provision, and we will see that it happened also in the funding of care. This table shows a very long list of countries, and this is only a partial list of countries that has been providing the information in the platform. And we can see here the different strategies to recruit workforce. This is recruit among existing workforce and medical nursing students, retired health professionals, inactive health professionals, foreign trained volunteers, and other measures. And I just put it here. It's obvious that you cannot really read. I just want to show you the distribution and how countries implemented different strategies, and there were strategies that were implemented in almost all countries. For example, deploying professionals from other areas or other wards to treat COVID patients, and fewer countries could import physicians or health workforce, but countries were creative and they recruited from wherever they could. So this is very important, and the countries keep doing that because we know that workforce is still the main challenge or the main bottleneck for the provision of care. So in order to recruit all these new workforce, countries had to modify their work practices. So a lot of emergency legislation was put in place and they canceled leaves of physicians and they changed the registration requirements. I remember that in Israel, for example, health professionals could not leave the country. They could not go on vacations. They had to be there and provide care for the patients. Countries had to have a very good coordination between professional associations or national and regional health authorities, because they try to deploy professionals from one region to another region. For example, in Italy, when the pandemic was very difficult and very high in the north of Italy, physicians from the south moved to the north to help and provide care when the crisis was very difficult. So they had to have this good coordination with the regional health authorities. They had new contractual arrangements to modify the work schedules, increase working hours. They changed the night shifts. They relaxed the minimum staffing requirements, all this in order to let people work in different manners and according to the needs, so they could provide the proper care. A very interesting thing that happened in almost all countries is the loosening of recruitment or hiring requirements. So countries allowed the fast hiring of freelancers. They allowed short-term contracts. They allowed temporary contracts. So this was very common in many, many countries, mainly the countries that didn't have enough workforce from the beginning. For example, Spain, Italy, Portugal, Cyprus, and Israel are countries that didn't have any surplus of workforce. So they had to allow these flexible contracts to let these additional workforce work for them. The third strategy is redeploy health workers from disciplines, regions, and cities that were in greater need. So as I already told, the reallocation of health professionals from one ward to another ward, from primary care to hospitals, from one region that was not so badly hit to a region that was very badly hit. Some countries built centralized or regional online portals to match supply with demand. So, for example, in Italy, there was this online portal where the regions could exchange information, and they could know where were in what region there was a surplus of physicians that could be taken to the other region that was in more need. So all countries also provided additional training in person or online for health professionals to facilitate the scope of the practice. For example, professionals from primary care not necessarily knew how to treat COVID patients in hospitals, and they needed this speedy training. And many times this could not be done in person because of physical distancing measures, so it was online. And health workers that were in severe risk, they were sent to non-patient facing roles, for example, contact tracing or call centers. During the pandemic, people call the GPs to get information of where to get tested and how to proceed and how to get treatment, where should they, what kind of care should they seek, and these professionals can help with these tasks. And I talked about the private sector, so I won't talk too much about that. And now I want to move to the financing part of the talk, because this is very important to provide the right financial incentives for professionals, one hand, so they don't bankrupt during the lockdown, and they can continue existing to provide care after a lockdown or after the elective care is resumed. And on the other hand, we need the payments to incentivize providers to provide the needed care for these patients. So we classified the types of payments into two types. The first type is compensating income loss. So COVID has extra costs, but also a lot of professionals lost income because elective care was put on hold and fewer patients were coming, demand was reduced during the first lockdown, and even now it's not clear if all the elective care was resumed already. So we have to compensate the professionals for this income loss. And another type of payment is paying for COVID services, because COVID has these extra costs. The patients are very high risk, they are very high cost. Hospitals suddenly, the average length of stay of a regular non-COVID patient is about 4 days or 5 days, up to 8 days, and a COVID patient can stay in a hospital for 2 weeks. And they use very expensive equipment. They use ICU beds for very long periods of time, and hospitals face higher expenditures, so they have to be properly paid. And also providers in the community, right? Primary care and specialist care in outpatient settings also have these higher hygiene requirements and physical distancing requirements. So they have to be properly reimbursed. And I'm gonna give a few examples of new payments that were created during the pandemic. So we have higher payments that provide a higher fee for the patients, for the providers, because they have to face higher risk and more complex patients, and also because they have these extra expenditures. We have new types of payments, and we will see that there were old payments that were good and resilient enough, so providers didn't need any kind of change of payment. And there was a lot of changing in the payment mix, and you're going to see that this was very interesting to learn. So the first one is compensating income loss. As I said, the payments have to balance the aim of compensating for income loss, but also at the same time provide incentives to restructure service provision. Because if you compensate for loss, what incentive would providers have to resume activity after the lockdown? So what countries did is a lot of countries provided the same payment that were in place before the pandemic. So for example, GPs received salaries or capitation in many countries. When they have salaries, it doesn't matter if the patient comes or not, because they receive the salary anyway. So this is an old payment that didn't require any change. We call this in health economics a resilient payment. Also, physicians got payments based on previous year turnover. For example, in England, Lithuania, and the Netherlands, the providers received the same amount that they received in the same period 1 year before. Many countries started paying for e-health, for example, telemedicine and remote consultations. So providers could continue providing care although they were isolated or although the patients would not come to the practice. And this was a way to incentivize the provision of service. And in the first place, people could continue get treated although there was a lockdown, and the provider was incentivized to keep providing care. Obviously, all professionals in all countries received sick and quarantine leaves, because if they cannot work, it's not fair that they lose their income. Many hospitals also use target budgets. So for example, if in Israel we have a capping in the income of each hospital from each health plan. There is a ceiling, but there is also a floor. It means that if a hospital did not provide the same amount of care as last year, but provided less care because patients forgone care or because elective care was put on hold, they still receive the lower cap. It means that they receive 93% of previous year's income. So they have some kind of income guarantee, even if they don't provide the service. And this is very important for a lot of countries and for a lot of hospitals, because this gives them it mitigates the risk of the fluctuation in the demand for services due to COVID. This fluctuation in demand of services does not exist in normal times, right? So it's not really necessary to have this compensation based on previous year turnover in usual times. But when it comes to a pandemic, when we have lockdowns and services put on hold, this is very important for hospitals not to bankrupt, for example. Another type of payment is compensation. Actually, payment given to providers if the income falls beyond a certain threshold, for example, 10% or 30%. And countries use different strategies. For example, Germany gave a special fee per quarter for each physician whose income fell more than 30%. In Belgium and Luxembourg, they chose to give this allowance on a monthly basis. Czech Republic preferred to give daily compensations. Each day that the provider does not receive a patient, he receives a certain reimbursement, compensation. Some countries prefer to give one-time lump sum for the whole period. So, for example, the whole period of the first lockdown was they got a certain lump sum for this period where they could not work because of lockdown. Many countries also started paying new fees, sometimes higher fees for teleconsultations. Hospitals received cash advance and also payments for e-health for outpatient settings. Physicians got also higher payments. So for example, higher fee for service, higher fees for after hours, and higher capitations. So they would not bankrupt or would have enough money to keep working. A very interesting payment that was put in place in many countries was suspending activity-based or quality-based payments. For example, in England, the physicians and hospitals got the regular payment without the quality-based, the pay for performance payment. And this provided them with some kind of security of the income that they could receive during the pandemic. I will just go very fast through the other payments for COVID that were put in place. So we already talked about higher salaries and higher fee for service for physicians. Hospitals received higher fees for COVID-19 patients. For example, higher per diem rates or higher DRGs, add-on per cases if the patient was in a severe case, or they received a higher fee for services also. Physicians received bonuses from for professionals after the first wave as a kind of recognition of the risk and all the efforts they did to treat the patients. And let me see what else is interesting. And also hospitals and physicians received in-kind provision of equipment in order to be able to keep working. So for example, testing equipment, personal protective equipment was given in kind in many countries, or they were given in cash allowances to buy these materials. Many countries received, hospitals received the ventilators and the ICU equipment in kind from the Ministry of Health, for example. Many countries also received private donations, for example, Bulgaria, where the private companies and even individuals decided to donate money. And in Spain and Italy, the people would donate personal protective equipment. They would go to hospitals and give their own masks to health professionals because there was a very high shortage of this kind of equipment. So just to finalize the financing part, activity-based payments pose risk on providers, not only for payers, and this is different in pandemic times from usual times, where in usual times we don't have fluctuation in the demand of services, and that happens in the pandemic, and this is very unusual, and therefore providers have to be compensated for income losses, although the general thought is that during a pandemic, the health workforce is just overwhelmed, but there are these professionals that just lose their activities. Fixed budgets are good because there is no need to compensate for income loss, but there are low incentives to restructure activity in line with the pandemic. We saw that governments and public payers assumed the cost of COVID-related financial risks. They did not leave hospitals and providers by themselves, and they supported them financially, not to bankrupt and to keep providing care. There were a lot of countries that adjusted the payments for COVID. For example, provided higher fees and higher salaries and higher DRGs and higher per diem rates, so they could be properly compensated for the services they provide and for the risk they assume. And the payments for COVID should reduce the incentives for selection and also balance the incentive for efficiency. And I think that maybe I should stop talking now, right? So people can ask questions. Is that so, Professor Katz? But you are muted.
Questions already here. One question is immediately with regard to the public health. Is there any indication from the Europe data as to which strategies have worked? Are there good good strategies that have worked well, and what are the indications that you would use to say good strategies work well? It's a question from David Lander.
So I think that it's all a question of the context. So, for example, a country that has a very high rate of workforce professionals per population, they did not have to recruit workforce from the army, for example. Other countries did have to recruit workforce from the army because they were in shortage of professionals even before the pandemic. So I don't think there is one answer or one strategy for every country. What is certain is that for public health, it is very important to maintain this chain of finding, testing, tracing, and isolating and supporting the isolation case, because this is the only way to curb the spread of the virus. And the challenge and the question is how each country manages to maintain this chain working properly within its own characteristics. So, for example, countries that are very decentralized, like Spain, like Italy, like Germany, federal states, they have the independence one from another. How can you ensure that all the regions have more or less the same capacity? How can you ensure that there are no disparities, and people that live in a rich region are not better off than people that live in a poor region? So this is a challenge that, for example, Israel doesn't face because it's such a small country and because it is very centralized. The same with Portugal. So each country it has its own types of challenges, and this is why we saw many responses that were very similar but also very differentiated among the countries. I think that context is very important here.
So would you say that the Portugal or Israel systems worked better than, for example, the Czech Republic system or the Baltic state system?
I don't think we can already say. I think that we cannot assess how well countries perform, and I will tell why. How can you assess? Do you measure the number of deaths? But deaths are very correlated with the age of the population. So countries with a young population will be better in a better ranking because less people die. Or, for example, countries like Israel, they can close the borders very easily. So it's not fair to compare. I think that we have to look at the context and see how well responses were governed, how governance was done. But what I can say is that at the beginning of the pandemic, even the decentralized countries, they took measures on a centralized way. So, for example, Spain and Italy and Germany, that are decentralized countries, even those countries had the central government, the Minister of Health, making the regulations and the initial responses. And afterwards, while the pandemic slowed down a little bit, they could decentralize back to the regions. So it is true that for centralized and small countries, it is easier to have these kind of measures because you have more control. But sometimes it's also a disadvantage. If you have, for example, in Israel, all the public health measures are the same for the whole country, and we know that we have cities with higher infection rates and higher morbidity and higher mortality rates. Why should these cities behave or have the same limitations as a city with very low morbidity rates? So it's also good to move to a decentralized response because it can fit and adapt to each context. And then it's easier for people to comply, right? Because they feel it's more fair and more adequate to their own situation.
Now, two people and several people have in fact come up with the question, Peter Abrams and Daniel Stetsky, asking questions: why UK, France, Italy so much worse than Germany, and why Germany appears to have a low mortality? Is there anything that you could say explains that?
Well, I think, okay, for Italy and Spain, the pandemic arrived earlier. They had their first cases in December or January, and the pandemic started very fast in those countries. So it's not that these countries were not well equipped or not well prepared. It's just that other countries were watching what was happening in Spain and Italy and could prepare themselves. And a lot of countries like Portugal, like Israel, like Malta, like Cyprus, Greece, they reacted so fast that they started with the lockdown, or they closed their borders even before one single case occurred in their countries. And then you had this very mild first wave in those countries, and then they opened they relaxed all the measures very fast because they were sure they fitted the pandemic. But then it started all over again in the second wave, and then they were hit harder in the second wave, while countries that were hit very hard in the first wave were more careful and relaxed the lockdown more gradually. So the second wave was more controlled. Now, the UK, I think that, if I remember well, the government decided not to impose the lockdown at the beginning because there was this, like the Swedish case, this kind of belief that you should not intervene and wait for the herd immunity, and then the policy changed on the middle of the way, and then UK decided, okay, it's not working, let's do the lockdown. So I think that the response reached in the UK a bit later, when a lot of cases were already in place. So I think that the timing of the responses and the timing of the lockdown was very important. Germany responded very methodically. They had this preparedness plan for pandemic, and they followed it by the book, like good Germans. So the responses were based on evidence. They were based on numbers, on morbidity, on mortality, and number of people in ventilators. So the responses were more, let's say, logical. While in Israel, for example, they were more hysterical. They responded because they were so scared that the healthcare system was already stretched even before the pandemic. If a pandemic would reach Israel, they would not be able to respond properly. So some countries responded in a kind of a domino effect. They saw what was happening in Spain and Italy, and they probably responded too early, and other countries responded too late. So that's my opinion.
So the degree of organization in Germany, pre-organization in Germany, was the factor that you're highlighting, essentially.
So many countries, and in fact, all countries had this preparedness plan for pandemic. What happened is that many plans were obsolete, or they did not fit COVID so well because they were built based on the flu model, or they were not updated, or they were not really implemented. So this is why many countries that followed the preparedness plan, and that they had the preparedness plan up to date, they performed well. And that was the case of Germany and Portugal, for example. Portugal had a very good and updated preparedness plan, and I think that helped Portugal to cope with the pandemic in a good way.
Now that leads one on to the two further questions that arise from that. One is that France, they appear to have the only additional healthcare workers they appear to have were volunteers. They didn't go for any other kind of returnees, medical.
I don't remember. I will have to have a look at the presentation because I don't remember by heart.
It was on volunteers.
Yes. So what's the question? Let me have a look at France. Yeah, that's right.
which is unusual. I mean, has that contributed to the death rate there?
Probably what happened in France is that they had a very high density of workforce even before the pandemic. So it was probably enough to cope with the pandemic compared to other countries like Greece or like Israel, where we know that there are lower than average density of workforce in normal times. So probably in France there were enough workforce, but to be honest, I am not so acquainted with the details and why they chose not to recruit professionals from other settings apart from volunteers.
Now, there's the method of financing in Portugal and in Germany. Does that impact on the outcomes there? Do you think it's anything to do with the method, the way their healthcare is financed, as well as the way the preparedness?
So Germany had a lot of compensation and financial support for hospitals and for providers, and they kept working even during the lockdown. So it's true that some elective care was put on hold in hospitals, but the outpatient care was active during the lockdown, and this is because physicians got compensations. And for example, hospitals received per diem rates for empty beds, and this was a kind of compensation for the surgical wards that did not receive any kind of income during the lockdown because surgeries were put on hold, and they could resume the surgeries very fast after the lockdown was relaxed. So when you have these financial incentives and you don't let the provider to bankrupt, they can resume activities faster. Portugal, I don't remember what happened. I do know that countries that were more generous, that had more generous funding, could impose the lockdown for longer periods because they could compensate providers and citizens for this loss of income. And this is one of the reasons, for example, why Israel had to lift the lockdown relatively early, because they didn't have enough money to give to families and to professionals and to workers in general to stay home. So that was the trade-off at the beginning of the pandemic of whether to relax the lockdown or not. And it happened in all countries. And here in Germany, they could relax more gradually the first lockdown because they gave a lot of support for families, children allowances, and support for all the professionals and for health providers as well.
And there's one final question is really relates to, from Simon Cohen, relates to the question of the scientific experts getting their message across and adopted by politicians who may have different priorities. Is there any lessons to be learnt? In the UK, we see experts talking and sometimes not saying the same thing, sometimes saying the same thing. Is it possible in a democratic society to actually manage to achieve some kind of communication?
Yes. Oh, so this is interesting because I think that almost all countries consolidated some kind of expert group of professionals to advise the policymakers at the beginning of the pandemic. And the composition of this expert group could vary, and all of them had epidemiologists and public health physicians, but some of them had physicists and mathematicians and people from computers to build these models to see how fast or how would the virus spread and how many people would be sick, and make projections over time. And at the beginning of the pandemic, the governments really listened to this panel of experts. And while time passed, more groups appeared independently, and they had different opinions. And also governments probably stopped following the recommendations of the experts because they had other priorities, as you mentioned, not only the pandemic or not only the public health priorities or not only the morbidity and mortality. Sorry. Not only these kind of considerations, but also economic considerations and political considerations. And we know that in Israel, a lot of the measures were put because of pressure of certain groups of population that were opposed to a second lockdown. And it led to illogical measures. So for example, around Sukkot, around the holidays, there was the lockdown, but people could go and shop all the supplies for the sukkah. So either you have a lockdown or you don't have a lockdown. You cannot leave children at home without schools and let people go and shop supplies to build a sukkah. And this leads to not very efficient policy making, right? And not efficient responses. And that happens in all countries actually now.
We have one comment is that you shouldn't, from Alan Salama, you shouldn't exclude the UK from using the modeling on the basis of flu, because UK also based on flu rather than on only when more data arrived did they realize that flu wasn't the appropriate model. I mean, are there many countries that used flu as the model, or was it?
Yes, many countries, and they understood very fast that these models were probably not very accurate, and then they modified, and now countries have a modified preparedness plan for specialized in COVID, and now they try to follow that more or less.
Right. Okay, well, thank you very much. It's a very interesting, and you've taken us an overview of a very complicated problem and shown us a lot of different, provided us with a lot of food for thought. So it's now well past 10 o'clock in Germany. So I'm going to say thank you very much. And I hope you enjoy the rest of your stay and good luck with the PhD.
Thank you. And thank you for listening.
Thank you.